session. We welcome you. We appreciate your presence today. We are hoping the other participants are still coming, so we will continue with our session in the interest of time. So I would like to acknowledge the India team for guiding us and helping us going forward from the beginning up to this far. I'd like to acknowledge your assistance as we are going on with our sessions. My name is Savelo Lukele. I'm a palliative care nurse under Eswatini Hospice at home. I'm based in Manzini region. So today I'll be the facilitator. With me, I have my team from Eswatini Hospice at home. I think they will going to introduce themselves. So welcome to our today's session. In this ECHO, we capacitate each other. We are trying to fill the gaps in the areas of healthcare. This is the platform whereby we all learn. This is a platform whereby we acquaint ourselves, especially here in the areas of palliative care, because we are doing palliative care. So it's a very important platform for us as healthcare workers. For today's session, we are starting a new chapter today in communication. We all know that communication it's the center or it's the heart of palliative care. Without a proper communication, palliative care will not be effective enough for us as healthcare workers. So today we'll be doing our first piece of communication, which is core elements of clinicians communication. So we have to pay attention for it. So I have mentioned earlier on that communication here in palliative care is a very, 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 very important aspect in palliative care. So our very own sister here is going to take us through the communication here. It's a reminder, colleagues, that we switch on our cell phones to silent mode so that it cannot disturb you or the next person. We also encourage active participation for everyone. We can indicate by raising your hand, or we can indicate by writing on the chat box. You introduce yourself, your name and your surname, your role, the role that you play at your facility. Also, we're gonna have our presentation, case presentation from Manzini Oncology, as we are going through our session for today. So without any further delay, I would like our team to introduce themselves. I will start from my team here, Eswatini Hospice at home, to introduce themselves so that we can continue with our session.
Good afternoon, colleagues. My name is Mercy Shabani, and I'm with the Eswatini Hospice at home HAP team.
Good afternoon, team. My name is Bomi Mabu Sala. I'm the administrator at Eswatini Hospice at home.
Good afternoon, colleagues. My name is Gomez Melani, based at the clinic here at Hospice at home. Thank you.
Good day, colleagues. My name is Samuel Nkampunye. I'm a palliative care nurse under Bombo region here at Eswatini Hospice at home. Thank you. Thank you so much, Tim. I would like to welcome Enza Mwamba. If you can hear me, we would like for you to introduce yourselves to the whole team.
Thank you very much. Dr. Enzia Mwamba from Lubombo Referral Hospital.
Thank you so much, sir. And I'll also acknowledge Nombumelelo Dlamini, I suppose from the oncology unit. May you please introduce yourself? Hello, Nombumelelo, can you hear? Can you hear me? Can you hear us?
Hello,
Yes.
can you hear me?
Yes.
Can you hear me?
Yes, Nombumelelo.
Okay, my name is Nombumelelo Dlamini from Manzini Oncology Unit. I work at the chemotherapy department, the outpatient department, as a nurse.
Okay, thank you so much. I think the others, please unmute your microphone
Sorry.
after your speech. And also, Mr. Mwamba, please unmute your microphone, sir. Yes. Okay, without any waste of time, I would like to introduce Ms. Mercy Shabangu here, who is going to take us through our session today, our didactic, which is core elements of clinicians' communication. Over to you, sister.
Thank you, Mr. Likele. Afternoon once again, colleagues. Today I'll be taking you through the core elements of clinician communication. I think as Mr. Likele mentioned before, this is just an introduction as we are going to go deeper in a couple of weeks looking into communication. So this is basically the base of what will help us build on as we look at communication. So I'm going to quickly go through the objectives of this presentation. The objectives are to clarify how a clinician imparts information, to identify information gathering skills, to discuss listening skills models, and to clarify eliciting sensitive aspects of care, which include culture, religion, and ethics. Now, communication is a two-way process of sharing and receiving information. And in palliative care, we usually consider communication as the cornerstone because it actually affects both the quality of care and the quality of life. What we mean by that basically is that if there is poor communication, the quality of care of the client will be very poor, which will also impact their quality of life in a very negative way. Communication is used in palliative care as an aspect of influencing symptom control, understanding of information, decision-making, abilities to cope, and it's also a therapeutic tool in palliative care. So if communication is done effectively, we are able to actually work around the symptoms of the client, because we will have gotten the right information from them about what they're actually suffering from or what they're actually feeling. And then we'll be able to actually relay the information to them in the way that they can understand. And this helps them to make better decisions, and it helps them to cope better with the condition or the diagnosis that they have received. And in palliative care, we look at communication in the sense that it is what families will remember you, is what families will remember about you in the care that you gave their loved ones. So if the communication was done effectively, they will remember you in a good way. But if you are not able to communicate well with the client and the family members, then you would have painted a bad picture, not just for yourself, but also for all healthcare workers. And another important thing to know about communication is that we cannot not communicate. There's no ways that you can get to a point where you say communication is impossible. The first element of communication that we are going to look into today is the imparting of information. So this is basically the clinician's primary role, to impart information to the client. The kind of information that can be imparted by the clinician could be illness education, where you educate your client and the family members about the illness that the client has. It could be information about medication, treatment, or treatment information, so the kind of medication that they're going to receive, how they're supposed to take that medication, what are the benefits and side effects of that medication, and also the kind of treatment options that are open for them, their harms, their benefits, their risks, and actually the process of how the treatment goes. You can also impart the diagnosis, information about diagnosis, the prognosis, and the treatment options, as mentioned before. So this kind of information can be shared within a certain context. We'll look at a couple of things where we look at how this kind of information can be imparted to the client or shared with the client. So it should be within the context of educational level. We understand, colleagues, that our clients are at different levels when it comes to education, and us ourselves as health workers are educated at different levels. So it's very important to understand the level of education that your client has, because this will influence the kind of language and how you will actually explain everything to the client. You cannot just use a same way to communicate with all your clients, but you actually make note of their educational level. There's also aspects of sharing the information that you might not actually be well versed in. So it is important to seek the informed consent of the client, to actually invite another professional to help you as you discuss certain areas of the client's health, in order for the client to have all the information that they require, and in order for the clients to have all their questions answered. Another element we need to look into is primary language. So we are encouraged to use the client's primary language, not your primary language as a clinician, because you might have a different primary language from the clients. And if there's an issue that your languages are not the same, you could actually get an interpreter to make sure that the client is able to get all the information in a simple and plain language that they are able to understand, and in a language that they're comfortable to engage in. Another element is the developmental level. So as human beings, we go through different developmental stages, and our clients, and work with clients who are actually in different developmental stages as well. So the way that you are going to share information with someone that is a child or an adolescent, and the way that you're going to impart information to an adult is going to be different. So the developmental state or the developmental level of the client actually guides you on the kind of language and the kind of setting you could actually set up when you are sharing this kind of information with the client. if I make an example, when you're talking to a child, you'd probably find a more suitable place for them to be in. The room that you're going to be using is going to be different from when you are talking to an adult, because you want the child to be as comfortable as possible. And there's also a psychological state where you need to note which psychological state your client is in. And this actually influences the manner of approach that you're going to use to engage with the client. Because if the client is not feeling well, or if the client is sad or depressed, you have a different way of approaching them in imparting information. And also, if the client is very happy, you can't just drop a bomb on them. You just find a way of actually communicating the diagnosis or the medication or the treatment options to the client according to their psychological state. And still on imparting information, it is very important to consider verbal and non-verbal communication. We cannot leave that one out, because the principle of verbal and non-verbal communication is an essential component of narrative practice. There is no way that you can only focus on what the client is saying, but not on how the client is actually reflecting or actually showing non-verbal cues. The second element that we are going to look into is the information gathering. With information gathering, this is where you as a health worker or a clinician gathers information from the client. So what happens here is that we use open-ended questions in order to get as much information from the client as possible, because in this case, we try not to say too much to the client, but we make sure that whatever we ask the client is actually able to expand as much as possible, so that they can be free to say whatever they want to say without us being limiting or being specifically directive to what we want from them. Open-ended questions promote the opportunity and richness to listen to the client's or patient's narrative and to observe nonverbal communication, as we mentioned before. Now, what we can benefit as clinicians from asking open-ended questions is that we can be able to get an expression of the client's values, the priorities of care according to the client, life priorities, and spiritual concerns of the client. Because if we are able to get all these, the expression of all these values and priorities as mentioned, it is easier to work with the client moving forward, because now you understand what they value and how they prioritize their things. You are not going to be imposing what you think is important, but you will be working on grounds that the client has given you, that this is important for me, this can come first, this is what I'm concerned about, and spiritually, these are my concerns. So we are not encouraged to use close-ended questions, which basically give us a yes or no answers, because those ones are very limited. As soon as you ask the client the question, they'll give you a yes or no answer, and that is all they have to say about it. But the moment you use an open-ended question, they are able to actually say more. They are actually even able to ask questions. And as a clinician, when you ask an open-ended question, it is essential to listen to the answer. You are not listening to give answers to the client, but you are listening to hear what they really want to say and what they really, and the way that they want to be supported in. So we are going to be looking at a few useful open-ended questions that you can actually use to initiate discussion. One of the questions that you could use with your client is to ask, how are things going for you? This is the kind of a question that will allow the client to actually tell you about different aspects of their life. They will not only probably focus on the physical, as we may think that their problem or their pain is just a physical kind of pain, but they will also touch on emotional issues, they will also touch on cultural or even spiritual issues. And you might find that the condition that they are having is not their major problem. There's other things that they can be able to talk about just from this question. Another question could be, what concerns you about your illness? This is where the client is able to say a lot about their condition, and this is where you are actually able to get how much information that this client have about their condition or their diagnosis, and actually the accuracy of it. This is where you are actually able to also see issues of denial or anger or anything like that. And then we have, how is the treatment going for you? So instead of asking, is the treatment okay or not? But when you say, how is the treatment going for you? Now they'll tell you, the treatment is really working out. I think it's working for me, or I think it's costly. That is where they're able to actually say a lot of things than just giving yes or no answers. And then another question could be, what concerns you about your treatment? This is where they'll probably bring up issues of side effects that they're experiencing from the treatment. An example with chemotherapy, some of them might say, my hair is falling off, or my fingers are turning black, or something like that. That is when you also get a chance to discuss those side effects with the client, what the benefits are, and what the client should actually anticipate moving forward. And then one last question that we are going to look at is, who are the people who provide you support? Now, this is when you will be able to see the kind of support system that the client has, and actually the people that the client wishes could be involved in supporting them. Now, this makes it easier because when we are looking at the aspect of support, we are trying to figure out that if this client needs the facility, who will be there with them at home to help them with medication, to help them with, probably remind them with about their appointments in the hospital, and actually help them with financing them in terms of their medical needs. Now we are going to look at the third element, which is listening. Listening is an active process that requires concentrated presence and attention. During this process, the clinician listens to the patient's story without interruption. So we are really encouraged to listen to the patient's story without interrupting them in any way. There's a lot of interruptions that could come in. It could be your phone disturbing you. It could be someone else coming into the room and disturbing you. It could also be you just popping questions during that session with the patient. Now, as you are listening to the patient, it is very important to make note of the following things: the specific word choices and the concerns that the patient makes, or that the patient makes use of. Because specific word choices could actually give you a picture of how the patient is actually viewing the entire thing. They could be saying certain words probably anxiously or with anger, or they could actually be avoiding a certain term. So that gives you a picture of where the client is actually standing. You should also make note of or focus more on what is being said by the client, and also what is left unsaid, because there's also could be issues lying underneath things that the client has not said. You also note the speech pattern, the tone, the rapidity, and the coherency. Now, with the speech patterns, it is important to make note of this, because sometimes the client might be moving from one point to another, or really avoiding a certain topic as you were talking about their condition. And sometimes the tone could be really fast, which could show that the client is anxious, unless the client is naturally a fast speaker. So it's important to make note of that. And then we also make note of, or we observe verbal expressions, which include emotions accompanying physical movements. There's nothing that we take lightly, and there's nothing that we overlook when we listen to a client. Now, during the listening, or as we use listening as a core element of communication, we make use of open-ended questions, as we have mentioned before. And we also use silence, and silence is said to be very paramount in listening. Silence is not meant to be awkward, because no one is in a rush, or there is no rush intended actually in communication. So silence is important because it allows individuals to process the question. Maybe you've posed a question to the patient, so it allows the patient to actually process the question. It allows the patient to take in what you've just told them, the diagnosis, to make sense of all the information that you are sharing with them. So there's no need to rush or feel like maybe it's awkward that now the both of you are quiet, but silence is very important, is a very important skill that you can use in listening. And it actually helps the client to reflect on certain experiences before they can go on sharing more information. Listening allows the clinician to be fully present in the moment rather than mentally preparing answers or replies. Because the moment you're preparing for answers or replies, you start getting distracted. There's points that the client will say that you will miss. There's non-verbal cues that the client will present that you will also miss. You also use reflection to convey empathy. So in reflection, you are actually using some of the words that the client is, you are basically reflecting back to them what you've heard them say, and it actually provides clarity. So in this way, you are able to convey empathy because you are now viewing it or saying it from the client's frame of reference. I think there's a picture there that we can see of a doctor and a patient. And the patient is actually saying doctors don't listen to their patients. And the answer from the doctor is yes, there's a lot of it about. Clearly here, the doctor is not listening to the patient, or the doctor is in a rush to actually give answers to the patient. So can you imagine what's going to happen if this patient is actually consulting with the doctor, telling them what's wrong with them? There's just going to be a lot of miscommunication going on here. Now we are going to look at the models of listening in palliative care. The first model we're going to look at is the ask, tell, ask model. So what happens here is that the clinician asks the question, the patient responds with both statements and question. It could be one or two. It could be either just a statement alone or a statement going with the question. And then the health worker or the clinician then responds to the content of discussion, and the health worker closes by asking a final question to determine the patient's understanding. So in the ask, tell, ask model, you don't just tell the client first, but you ask in order to know or get a picture of where the client is actually standing, what the client knows, what the client wants to know, how much of the information that you have does the client want you to share. So you ask first before you share with the client. Then from asking, it's either you got a statement as a response from the client, or you got a question as a response from the client. Then you are able to tell the client based on what you know that they have, or based on the kind of information that you know that they have and the kind of questions that they have. Then you're able to tell them. And then you're able to also close with the final question just to ensure that you are on the same page with the client. The second model is the spikes model. With the spikes model, it's basically, it's broken down, as we can see. The S in spikes model talks about the setting. This is where you secure an appropriate area for discussion with the client. It's basically important for listening skills, yes, but you get an appropriate area for discussion with the client. This kind of an area could be a quiet and undisturbed area. And you prepare yourself as a health worker, what you want to say to the client and what you actually anticipate to be their reactions. So you do your research. And you also have the key people, which is people that the client want to be a part of that session. And then we have perception, still on the spikes model, we have perception. In perception, this is where you assess the patient's understanding of the seriousness of their condition. Now you want to see how much they understand, and it could be the client alone or the client and people that the client wanted to be a part of the session. So you want to know how much they know about the condition. This is where you assess their level of understanding, and this is where you take note of discrepancies in the patient's understanding and what is actually true. And here you can also watch for signs of denial. And then the next step in the spikes model is the invitation step. This is where you get permission to have a discussion. You ask before you tell. So here you could ask a question, or you could say a statement like, I'd like to go over the results. Would that be okay? So before you even start giving the client the information, you check if they are ready for that kind of information. And it is the client's right to accept whether they want to know or they don't want to know, how much they want to know. You also offer to answer questions that the client may have or the family members may have as well. Then we have knowledge. This is where you start explaining the facts to the client after knowing how much information they want to know. Here you avoid medical jargon so that the client can be able to understand what you're trying to say to them. And you give them the information in small chunks, and you always verify or check after giving them that kind of information if you are still on the same page. Then we have emotions, which is another stage. With emotions, this is where you are able to give empathetic response to the client. Here you deal with the emotions as they occur, and you respond to emotions with empathetic and affirming statements. And then we have the last step, which is strategy and summary. Here you decide the best medical plan for the client, and you clarify with the client the expectations of the treatment and outcome. You strategize with the client, and you collaborate and agree on a plan, and then you summarize the entire session. We are going to look at the third model, which is the SOLO model. With the SOLO model, we are looking at the setting or how you can sit with your client as you discuss or as you communicate with them. So we are encouraged to use a squarely opposite sitting position with the clinician instead of sitting across the client. This allows the client not to look at you directly. They are free to look at you. Also, they are free to look at the other side, other than having them sitting right across you. We also look at the area of you as a clinician having an open body posture. Because if you sit with your arms folded or with your legs crossed, it could seem like you are defensive, or the way that you are seated in, it could seem like you are uncomfortable or you are in a rush. Another model is leaning in to demonstrate using empathy. So when you lean in, you show interest to the client, and when you lean in, you show that you are interested in what they are saying, instead of sitting back, because that would seem like you are distant and you are not interested. And then you maintain eye contact, the appropriate eye contact depending on the kind of culture or the kind of client that you have with you. And then we also have relaxed position. So you're supposed to sit in a relaxed position as a clinician. Then the last model is the nurse model. With the nurse model, this is where we work around the emotions. Here you help the client name the emotions. You could say statements like, it sounds like you've been worried about what's going on. So now you'll be able to start naming the options, the emotions with the client. There's also understanding the patient. So here you could say, if I understand you correctly, you are worried about, and then you go on asking the client. There's also respecting the patient. This is also where you can offer support to the patient, and then you start exploring the patient's concerns. Can we continue? Now we are going to look at the sensitive aspects of care. We are going to look into culture and religion. So cultural competence is very important during communication, because respecting cultural diversity is key to delivering comprehensive care across the illness trajectory. Cultural competence promotes the patient-centered care through sensitive negotiation of therapeutic goals. And with culture and religion, these two play a role in the expectation of the sick persons. So it basically influences what the client expects, the beliefs about the cause of the disease, the autonomy in decision-making, and family involvement in information and decision-making. It also influences issues of end-of-life preferences and DNR issues. So it is important to practice cultural competence, because in this way you will not step on the client's, will get into the client's boundaries with regards to their culture and religion. Thank you.
Thank you so much, Mercy, for an informative presentation about communication. I noted something very important here, that in communication, the most important stakeholder here is our client. So as health workers, we are not supposed to impose our values on a client. And we heard a lot about listening, and there is a quote that I would like to share about from Rich Simmons, which says communication is only effective when we communicate in a way that is meaningful to the recipient, not ourselves. So we have to as well consider the values of the client, because the client in our case here is our recipient. So an effective communication is very, very important in the aspect of palliative care. Thank you so much for the presentation. Now we are supposed to see if there are some comments from the participants. If there are comments, if there are questions, you are free to say whatever you feel like you have to say at this moment. I mentioned earlier on that if there's something that you want to share, please raise your hand, indicate by raising your hand or indicate by writing on the chat box. So I'm giving you this time for comments and for questions. Okay, it seems that it was loud and it was clear. So we will move on to the next item of our agenda, which is the case presentation from the Manzini Oncology Unit. I think Sister Nombumele Loye is ready for our case for today.
Sanbonan.
Hi.
Is it possible to display for me, maybe, the information?
Yes.
Okay.
Yeah.
Okay. So good day, colleagues. Okay, I'm presenting about a case line. We have a male who is 49 years old, who was diagnosed with T-cell leukemia, stroke lymphoma. So the main problem we have with this patient is he's got hearing loss. So basically, when we started with this patient, he was already having the problem of hearing loss. It was a problem which he was having before, but then it wasn't attended because he would go for the audio. Then they told him that the ears, there was a lot of work, they cleaned him, but then it was progressing with no follow-up onto it. When then the patient, when he goes for checkups, he'll be booked again for another day. So it's still progressing. Up until now, the patient reported that it was mild when he started. That was last year. So currently it's severe hearing loss. The patient cannot hear anymore. he was diagnosed with a chronic myelogenic leukemia. The patient, this one, it's a condition whereby the cancer cells, the blood is affected. So the patient was signed for bone marrow transplant. He's still waiting for that bone marrow transplant. The form was signed last year around August, but patient is still in line. There is no follow-up on what is happening there. So when the patient presented, he was presenting, okay, the severe hearing loss, I've said. Then he was complaining of dizziness. He was complaining of fatigue and abdominal pain. Presented with abdominal distension, which he said has been there for over a month. So patient was also diagnosed with a hepatosplenomegaly. So I think with the distension of the abdomen, that is what could explain the abdominal distension. So he also reported a history of fever and sweating. Our patient is a known RVD. He's on ART since 2016 and was also treated for susceptible TB in 2019. Sorry, that was a mistake. The 2016, it's 2019 actually. So the patient was diagnosed with leukemia and T-cell lymphoma via a liver biopsy, which was done in June 2021. Then there was a recommendation to do a follow-up test, which is an immunochemistry, which then differentiates between to diagnose if it's the leukemia or the lymphoma. This was also done in June, and then patient was then fully diagnosed in September 2021. So since June to September, they were still following up the immunochemistry. Then patient was diagnosed with the T-cell lymphoma in probably like in September, that is 2021. So an ultrasound was done, which revealed that the patient had a enlarged liver, which was measuring about 18 centimeters at that time. That was in June 2. And also the spleen was also shown to be enlarged at I think it's 18.4 centimeters. So also a pre and a post contrast was also done to confirm. So that was done in it was done in, not sure, but at a later stage, it confirmed then that the liver was still enlarging, which measured about, the liver was now measuring about 24 centimeters up to, then the spleen was measuring on 26 centimeters. So medications on which the patient was put on, he was on hydroxyurea, allopurinol, and these are the ARVs which was started on, and then currently on the ARVs, he's on TLD. So when patient was started on chemo, which he started on March, he was started on this regimen, a CHOP regimen, which the drugs, the CHOP, the C4E, we have cyclophosphamide, and then we have etoposide. We also have doxorubicin, which is it could be it's either idramycin or doxorubicin. Then he's also put on prednisone, which he needs for a month. Then he was also prescribed Cipro with the bloods, with the slow K, the calcium, and the gluconamate. These ones were prescribed due to the low electrolytes of the patients. And then also was also continued on the allopurinol, and these are the supplements. So a patient is a driver who she is currently on hold due to the disability of the hearing, and with taking the chemo. So patient currently is saying is just self-employed. He's married and he has a very strong support system from the wife. Like every time he comes for the medications, for all checkups, the wife is there. So he reported that he has never taken alcohol or practiced any tobacco smoking or any cigarette smoking. Patient has a mother who was also diagnosed with cervical cancer. Okay. Okay, with the vital, we don't have a advanced directives currently. With the review of systems, the temperature was 35.3, blood pressure 133/90, pulse 84, respiratory rates 19, and then the saturation was at 94%. Okay, on examination, the patient he wasn't dyspneic or anything. It was just I would say it was just mild, and then with the pain around 3 and 4. So ranking the symptoms which were present, we had pain, I'd say 2, because he wasn't agitated or anything. He just said that the pain was mild. With dyspnea 1, anxiety, there were no signs of anxiety. Agitation, that's just mild agitation. Depression, yeah, there's 0. The fatigue 2. Then we had nausea and vomiting, no nausea and vomiting reported. Anorexia, no. Patient is just clinically stable. He's well fed. No constipation reported. No dryness of mouth. Mobility he was okay. Okay, with the labs, I just chose this ones which are mainly recommended with patients on chemo. We check the full blood count. We have the white blood cells which were elevated, and also the red blood cells were also elevated. He had a low HB rating at 9.4. With our electrolytes, yes, the sodium and the chloride were also low. Then the creatinine was rating on 83 millimole. The BUN was 4.5. Those ones were within normal ranges. So tests which the patients did, okay, we said that the liver biopsy, which was done in June to confirm, to diagnose the patient on which diagnosed the patient on lymphoma and leukemia. I did mention the ones that he did the ultrasound and the pre-contrast, which diagnosed the hepatosplenomegaly. So the liver, you see, Lana, it was still enlarging from 18.7 to 26, and then the spleen from 18.4 to 22. So our plan is to continue with chemotherapy. Still the bone marrow transplant, it's still from since last year, patient is still on the list. There is still no report on how far the patient is. Then we are to monitor the patient for tumor lysis. On monitoring tumor lysis, usually we take the CBC, you monitor the uric acid levels, the LDH, the calcium levels of the patient, the phosphorus levels, and the potassium. Patient was rebooked for ENT on the 17th of May. So we are still going to get a report on what is being done there, but currently there is nothing there. And with the chemo that he is taking, the drugs are not, they do not have an effect on the ear stuff. So it's not the treatment that he is currently taking that could maybe be progressing the problem with the hearing. So we do not actually have a clear definition of what is causing the hearing loss. Thank you.
Thank you so much, Rosie. I think everyone was able to to hear everything that was said. It was audible enough and it was clear for everybody. So now I'll give this opportunity to the participants. I'll give this opportunity to the floor. If there are questions, comments, and recommendations from the participants, I'll give this time to them now. If anyone has a recommendation or a comment, please indicate by raising your hand or indicate on the chat box. Anyone going once, going twice? We have Mr. Ngambule here from Eswatini Hospice. The floor is yours.
Thank you so much, for the presentation. It was audible enough. Well, my question will be, I just want to find out as to how are you able to communicate with our clients since he has a problem with hearing? How are you able to communicate with him? Yes, I just want to find out my question then.
Oh, okay. Are you done?
Yes, yes.
Oh, okay. Okay, usually we if we want to ask something from the patient, we write down. Then because he's able to speak, it's just that he cannot hear. We write down whatever that we need to ask. But then I also feel like maybe the patient cannot be able to express himself much because, you know, with this hindrance again, I think he has the thing that maybe he feels like he's disturbing you, or maybe he's afraid to ask stuff. But usually we communicate with him via we write something. So when he's at the doctor's, he goes with the wife. So whatever that he says, maybe even if he has the complaint, the wife probably says whatever that is wrong with the patient.
Okay, thank you so much. Let's hear from Mr. Ngambule if there is something he wants to add.
Okay, thank you so much, Nkos. No, I just wanted to find out whether was there a way that you were able to communicate with the client. I think I also have, okay, it's not similar. I also have a client that we also have okay, he's unable to talk clearly. Also with Parkinson's. So his tongue is unable to talk very well. So usually when I want to communicate with him, usually write down on a piece of paper, or sometimes send a message over the phone because he does have my number. So I think it also helped because he is able to express himself through that way. So I thought maybe you also had maybe another way which I would personally use that will actually help me, because it's a platform whereby we need to help one another in trying to get better service for our clients. Otherwise, thank you for your answer.
Thank you.
Okay.
Thank you so much, Mr. Ngambule. What I like most about this is the home support system. Way back at home, it's very helpful to the client I would like anyone else to comment if any discussions, any comment, any recommendation, and any question.
Hello.
Yes, we have Sister Felicity. We would like to welcome you. There's something that you want to share. Over to you.
Yeah, hello, afternoon, team. Apologies for the late joining. Work is work. I just missed most of the presentation today, but from the leaflet I just got, I would say I would like to encourage the team members to learn the sign language, because we really have some communication breakdown or challenges with somebody either is just born deaf, or a patient who just happens to lose the hearing ability. I know I also, one time I tried to learn the sign language. It was difficult for me, but I think for others it's going to be easier. So team, please, let us learn the sign language. We do have such cases in the field. I thank you.
Thank you so much.
Thank you.
Thank you so much, Mr. Dungudu, for a wonderful comment. I would like to hear to see if anybody, I see a hand from Lompelelo.
Okay, thank you, guys. Thank you so much, Sister Felicity. I think also I was going to recommend that, and I think it's also, if maybe even the staff is well supported on that, even the patient, because sometimes maybe you can know the sign language, but then the patient themselves are not capacitated on that. So I think maybe if we can get that, they also have maybe the classes for both the patient and the staff, because it's going to be impossible if you are capacitated on the sign language and then the patient doesn't even know what you are talking about. But thank you so much for the recommendation.
Okay. Thank you so much. On your presentation, you mentioned something about the patient awaiting bone marrow transplant, and currently you mentioned that the patient is on chemo. So I just wanted to know if the client is aware of the goal of care, about all the procedures that has to be done, about the bone marrow actually, and also the chemo. Did you, as a facility, explain to a patient or to a caregiver about all these things?
Thank you, sir. Yeah, it was well communicated. The patient is aware, also the caregiver, they're aware, because even if you just talk to them, they are the ones who tell you in the progress that this is where they are. They know that they're still awaiting that, they are aware. Yes.
Okay, thank you so much. Okay, with the interest of time, I think it was well understood. Okay, Sister Felicity, I see a hand. Over to you. I see a hand from Sister Felicity. Is there something you would like to share with us? Okay. Thank you so much, Tim, for the wonderful presentation, for the wonderful session we had today. I would like to. There is on the chat box. There is a feedback link here. We need to all go to that link and do our feedbacks so that for the effective session. So all of us, let's go to that link and click there so that we can be able to give our feedback. So at this time, I would like to give this opportunity to Mr. Mathama before we close the session for today. Mr. Mathama.
Thank you so much, everyone, for participating to this session. And thank you so much, Sister Bomi, to say such a sensitive and great case. We understand that in our culture in Africa, when the man is suffering in the home, the whole home is now a patient. So we are not taking lightly the situation that our patient is going through. And we thank you so much, Sister Bomi, for the effort and all measures put in place to take care of this patient. Based on what you are saying, that a lot has been explained. We are moving in a critical topics on communication. It's a pity that now at this stage, I guess the prognosis and the possibility of this patient to recover has to be ascertained too, so that we need not to stay for a long time. So we begin to talk of to plan for the worst. I think now, while the patient has a hope on the chemo and has a hope on the bone marrow that we don't know when it will come, we may not keep the patient in limbo there while we are praying for the bone marrow that we don't know when it will come. But at this point in time, I will advise that we engage on advanced care directives with the family, so they plan for the worst. And now that the man is unable to hear or communicate well with everybody, I think the advanced care directive needs to be communicated to this man. So it's not okay that at this time around, with an uncertain diagnosis or prognosis, we are still in limbo of the outcome. We know that sometimes patients will die from lymphomas and especially leukemia. They will die sometimes, but if all went well, you will find that they recover. And looking at what is happening now, we discover that we need to put the advanced care directive so that the caregiver, which is the wife and the family, can be in a position to make a decision on what treatment should be given should this chemo is not effective anymore. So I think the issues of advanced care directives need to be taken into consideration. Sometimes advanced care directive does not mean that now we are going to withhold or withdraw the therapy that we are giving, but just to ensure that should anything worse happen when we are not expecting it, we are in a safe ground. Another thing I want to say is, it is good to know that the family has a supportive system that is so supportive. But I think rarely they will come, the children, the relatives, they will come for the oncology unit for counseling and support. You know, when the head of the house is sick, the whole house is sick. So, and these conditions, you will find that now they become, they happen like a genetic thing. You will find that in the family, one died of it and the father has, and the children might have. So some sort of counseling in this point is needed. Already this family is in a grieving period. but not grieving the loss of a husband, but the loss of an income in the house. So they need some support. So I will advise the oncology unit to take and prioritize linking this patient to a home-based unit. For example, in our organization, we have one that can be supportive to this man in terms of counseling and otherwise, because I think at this point in time, they need that. Another thing that we need to take into consideration is the issue of spiritual support. And this time when you feel like nobody can understand how you communicate with them, sometimes you need some spiritual support where your wife and your children cannot reach. The inner person has to do something. You know, as men, we know that once they get detached from the environment they've been in, they feel now vulnerable, they feel cheated. One time or down the line, you see this man now undergoing some stress, and you'll wonder why. He will feel like now that he cannot hear the sermons, he cannot get the scriptures. The question is how he connects to his supervisionary being can be a key for us as a team while we are bringing this curative therapy and the supportive therapy. So I think at this time, also the spirituality part of the patient has to be taken into consideration in each visit and each time of encounter with the patient. It must be reviewed and be checked and be encouraged. Even with the wife, the fact that now your bestie or your wife is unable to talk with you clearly like you used to be, spiritually and emotionally you are affected. So we need not to think of the curative part and think it is completed, but we need to embrace and get the stronghold in the spiritual area. And I saw that the man was employed, was a driver, of which we know in our country, driver is not earning much. And then now that the money that was supplying this house is already taken off, I think we need to sit down with the family. I think the issue of engaging social workers there can help in the issue of finding out the social support. It is good to get the family, but if now the man is not working, who is paying the bills? Who buy the soil? Who buy toiletry for this man? So we need to get all those things. Even the issue of transport to and from the oncology unit must be established. How much drain? You will discover that this man is not physically experiencing pain, but is spiritually suffering and psychosocially suffering. For now, I will say that, you know, sometimes the issues of intimacy, sexuality of this house, if the man is suffering, how is the intimacy in the house? Is not this wife now staying in this marriage just for the sake of being married? So there's a lot that we need to treat at this point in time while we are nursing the hopes of a bone marrow that we don't know when it will come. It's very good for now that this man can write things down. So I will advise that we start with the advanced care directives, that we continue refer this patient to a home-based unit. For example, cooperating or working, collaborating with the hospice at home will aid the oncology unit in taking care of this family. One day you'll see this man not coming, and then if it's not well lead, it will be very difficult to trace and find and how to support. Otherwise, this was a great case. I think we will need to reflect to it once more and again while we are going through the sessions. In our next session, we will be addressing the issue of family meeting, of which is one of the meetings that are required in this time of this man. So we will be looking at how can we handle meeting, family meetings, how do we initiate one, and how do we start and coordinate them, and why are they important to us as people who are taking care of these people who love threatening to have family meetings. So thank you so much. And our next session will be on the 18th of May, the same time, 22 on the 1300s. So we'll be talking about conducting a family meeting. How do we go about conducting a family meeting? May we encourage that we invite more people to come in, and we'll be equipping one another with the tools. Today's session was an introduction, so it aligns us when we are now going to the details of communication. We are able to use those tools in a different aspect. The first one will be conducting a family meeting. Thank you so much, everyone, for attending today's session. We hope you learned something. Thank you. Bye, team.
Thank you, everyone. Bye bye.
Thank you, Elena.